So good morning, good afternoon, good evening, wherever you are, and welcome to our new IFSO webinar on innovative bariatric procedures and ethics in bariatric surgery, discussing the new IFSO position statement led by the IFSO task force. The lead author is with us today, my dear friend and colleague, Dr. Ashraf Haddad. He's the chair of the IFSO Communication Committee, IFSO-MENA, scientific committee that is, and a member of the scientific committee of main IFSO. He'll be presenting to us the summary of their work, and with us are well-known esteemed panelists. I'll start with Dr. Lillian Cow, our immediate past president, director of Adelaide Bariatric Center, and past president of the Asia Pacific chapter and the Australian New Zealand Metabolic and Obesity Surgery Society. Also, Dr. Ricardo Cohen, director of the Center of Treatment of Obesity, Diabetes in Oswald Cruz German Hospital, and past president of the IFSO Latin American chapter and the Brazilian Society, as well as Dr. Jacques Hempens, past president of IFSO and director of the Bariatric Center of the Delta Church Hospital in Brussels, Belgium, and our current president, Professor Scott Shikura, director of the Center of Metabolic and Bariatric Surgery at Brigham and Women's Hospital in Harvard University. Welcome, everybody. It's great to have you all. And this webinar is going to be recorded, and you can review it on both the IFSO Virtual Academy and our YouTube channel. Let's start with launching the polls. If we can start with the first one, please. So, do you think ethics is or is not essential to the clinical practice of surgery in general, and in specific bariatric surgery? And I'll start with Dr. Cow. What do you think?
Well, thank you for asking me this very essential question. I think truly ethics is very essential to the clinical practice of surgery. I believe all surgeons are responsible for maintaining their professional standards and performance, and therefore doing what is right for their patients is essential in their practice. So doing the right things for the patient, doing the right thing by their practice is very important.
And I think the entire panel would agree with Dr. Cow, and let's see what the audience think. So surprisingly, 66% they disagree. They don't think ethics is essential to the clinical practice of surgery, unfortunately. Let's see if Ashraf can change their mind. Let's launch the second poll. This is the controversy that we're living in. I would offer an innovative procedure, if you can choose one of the following. If the concept seems feasible, experience of a single center versus under a study protocol and IRB approval, or only when recognized by IFSO or any major society. Professor Shikura, what do you think?
I think that you need to do any innovative procedure or any invasive procedure on a patient that's not been done before. You need an IRB approval to protect the patient. This is what got us into trouble back in the 80s and 90s, and why we had the same guidelines for 31 years was because we were doing human experimentation. Operations were popping up on a weekly basis. Surgeons were adapting things without any science in front of it, any animal work. It's really a slippery slope, and I think it's critical that we do that type of work with an IRB approval and consent forms.
So 44% agree with you, Dr. Shikura, under a study protocol, 8% if the concept is feasible and makes personal sense, and 6% would do it with a single center experience. However, 42% only when recognized by IFSO. So let's see what happens after Ashraf's presentation. Please go ahead, Ashraf.
Thank you. Dear friends and colleagues, I would like to thank you for joining us today. I would like to thank Dr. Ahmed Bashir for the invitation to present the position statement at this webinar series. And also, I would like to thank my co-authors, some of which are joining us as panelists today, for their support during this project. I think most likely this is the most controversial position statement generated by IFSO, and I'm honored to be able to share the position statement with you today. The title of this position statement is Ethics and Innovative Bariatric Surgery Procedures. This is my case mix disclosure. So there has been considerable rise in the number of bariatric procedures performed. And as you know, most of the procedures are being performed surgically, while endoluminal approaches constitute less than 5% of the cases. The laparoscopic sleeve gastrectomy and the Roux-en-Y gastric bypass were the most commonly performed procedures worldwide. However, recently, we have noticed that several new bariatric surgery procedures have been offered to patients. Some of them were reported in the literature early and were adopted, while risks and long-term outcomes were still lacking. And this takes us to innovation and surgical progress. Metabolic bariatric surgery, as you all know, is based on technical capabilities, knowledge, judgment, and the surgeon-patient relationship should be the core of the surgical ethics. The parameter of the surgical progress in the past has been the reduction of morbidity and mortality. But currently, other factors have come into play. Cosmesis, improved technical feasibility, economic efficacy, including the development of surgical tools, and developing emerging new procedures. So shorter, cheaper procedures are not always better, and the surgeon should demonstrate objectivity and compassion. And all of us as surgeons should place the patient's interests first and respect their dignity, treat them as individuals, and respect their autonomy. And all of us have stated that during our Hippocrates Oath. It's been said for more than 40 years by the Declaration of Helsinki. What are the basic principles that us as human beings, then scientists, and finally surgeons, we should abide by? We should conform to accepted scientific principles. We should respect the IRB, or the ethics committee. Research should be conducted by qualified and trained persons or personnel. We should have an objective assessment of risk versus benefit. And every patient has to be adequately informed and should have the right to withdraw. So if you're doing an experimental procedure or an innovative procedure, you should tell the patient, and he should sign a research consent, and he should have the right to withdraw. The IRB, or the Research Ethics Committee, is an integral part of any research project. And its primary purpose is to be an independent reviewer of the research proposal to determine whether they fulfill the ethical standards. Also, the proposal must be established and risks should be reasonable. That's why you need an independent reviewer to look at your research process. The final point is really important. IRB is a continuous process during your research. Informed consent. Before undergoing any innovative metabolic bariatric surgery, patients should be informed of the risks, whether the surgeon has done this procedure before or not, and what are the short and long-term outcomes. So if you're performing a procedure with no long-term outcomes, you should tell the patient so. Although the bariatric population is a vulnerable population as a whole, we should treat the bariatric patients like we treat adolescents or like the other special vulnerable group. And the reason is the bariatric patient has tried everything and he has struggled with this or she has struggled with this chronic disease for several years. By the time they come to the surgeon, they are almost desperate and they are willing to take whatever we offer them as surgeons. We should acknowledge their well-being regardless of the value of our research project. We should disclose any known risks to the patient as well, not just the outcomes, but the risks. We have to ensure that every patient participating in a new alternative procedure has given their informed consent. And we have to understand that all of us as surgeons have conflict of interest. And when I looked more into this, conflict of interest isn't just financial, and it's not just relationship with the industry. It could be a conflict of interest as an individual surgeon, a conflict of interest of the organization. It could be monetary gain. It could be just the fact that you want to advance your academic career. You want to get published. That's a conflict of interest. Or it could be that you want to create a new procedure. You want to name a procedure after yourself. You want to go around teach this procedure. This is also a conflict of interest. So we have to understand that conflict of interest it's not just monetary. It comes in all shapes and sizes and forms. So we have to conclude before discussing the individual procedures included in this position statement that surgical ethics should be the cornerstone of every surgeon's practice and every IFSO member. Surgeons should not only aim to reduce morbidity and mortality. We shouldn't just think of short-term outcomes. It is actually our duty to ensure that the procedures are safe, scientifically valid, and have proven long-term efficacy. An interesting concept that I came across while working on this position statement, and it's documented in the literature, it's called surgical exceptionalism, which means surgeons give a free pass to themselves that other physicians don't get. We think because we are surgeons, it's okay to apply new and alternative procedures, then look at their outcomes. And this doesn't happen in other fields. They study the medicine, they study the procedure, then they look at outcomes. However, it seems that surgeons feel it's okay because we are surgeons to do a procedure and then we can figure the outcomes later on. New or alternative procedures will be considered innovative or investigational until the published medical evidence regards them as safe and describes the risks and benefits and efficacy on the long run. First of all, we're going to talk about endoscopic procedures. Now, endoscopic procedures can be offered to patients that are suitable candidates. We have to counsel the patients regarding the risks and benefits, and most importantly, they need to have realistic weight loss expectations. We know that long-term efficacy data are currently lacking, and we recommend the use of RCTs and registries to provide long-term data. By our recommendation, we stand by the IFSO position statement regarding the endoscopic procedures. Sleeve fundoplication procedures. Upon reviewing the literature, sleeve fundoplication procedures in all its forms have a high postoperative complication rate, and long-term weight loss outcomes are lacking, as well as the efficacy in regards to controlling reflux. Now, there's no RCTs addressing their efficacy, and it is recommended that sleeve fundoplication procedures are only offered under IRB. And this is what you see. You see a sleeve gastrectomy, the fundus is spared and it's wrapped, and the wrap could be a partial or a complete wrap depending on the used technique. Nissen Plication procedures. Laparoscopic Nissen Plication data consists of actually single center small series with very short-term follow-up. Again, we do not know their efficacy in controlling GERD or in providing weight loss. Revisions of Nissen plications are usually technically challenging and carry higher complication rate and higher leak rate. If this procedure is to be offered, it should be done under IRB again until further efficacy and safety data are available. So with these procedures, they spare the fundus, they plicate the lower part of the up to the antrum like a regular plication, then they wrap the fundus around the lower esophagus. Now, this is a topic of hot sort of discussion worldwide. Gastric bipartition and SASI, which is the single anastomosis sleeve ileal bypass. Currently, there is no randomized controlled trials, and there is no proof that an enterohormonal imbalance related to obesity is corrected by these procedures whatsoever. It is recommended that they should only be offered under IRB and research protocol until we all figure out their efficacy and safety data. So this is the gastric bipartition. It's a sleeve gastrectomy with a Roux-en-Y gastrojejunostomy to the antrum and the jejunojejunostomy. This is the SASI. It's a similar, but it's a looped anastomosis. Now, sleeve gastrectomy with DJB. The sleeve gastrectomy with DJB seems to offer the benefits of the Roux-en-Y gastric bypass while not leaving an excluded stomach. This is important in populations that have a high incidence of gastric cancer and they cannot leave an excluded stomach. It was based on the same physiological hypothesis of the Roux-en-Y gastric bypass rather than a new unfounded data. However, long-term efficacy data is still pending. DJB can be offered to patients outside of IRB. And this is the sleeve gastrectomy with an anastomosis to the duodenum. Now, sleeve gastrectomy with JI or jejuno-ileal bypass. The sleeve gastrectomy with the jejuno-ileal bypass currently is being performed in several countries around the world. It is based on an unproven hypothesis, and this is important for our community to understand. So the hypothesis is that a JI bypass will increase the transit time, thus increasing satiety and incretin response postprandially. Again, this has not been proven or demonstrated. These procedures seem to set the patient up for the same complication of the old jejuno-ileal bypass of the 1960s and 1970s. If this procedure is to be performed, it is only to be performed under IRB after we explain to the patient the previous outcomes of the JI bypass. And as you could see, this is what's reported in the literature: a sleeve gastrectomy, a long blind end, a 75 centimeter sort of common channel, and a 75 centimeter what would be a ruling ideally, or it's a biliopancreatic limb. So only 1.5 centimeter available for absorption. Finally, Sleeve gastrectomy with ileal interposition. Now, this procedure is being popularized in certain areas as the gold standard of treating diabetes, or as a procedure to treat diabetes in normal weight patients. Sleeve gastrectomy with ileal interposition has no documented risk-benefit data or long-term outcome. Again, we are witnessing procedure based on a hypothetical unproven concept. Here, they suggest that an ileal interposition will cause the ileal break. The ileal break as a concept is not proven. And once the ileum is transposed proximally, it will, as you see here, and once this piece of ileum or segment of ileum gets exposed to food earlier, it's going to give cognitive feedback of satiety. Again, this is all just theories. Okay, this procedure is only to be performed under IRB. It has no data behind it. Two other procedures we're going to talk about are the SADI-S, or the single anastomosis duodenoileal bypass. As per the SADI position statement, IFSO supports SADI as a recognized bariatric and metabolic procedure. We encourage, however, RCTs, participation in registries, and long-term data collection. The one anastomosis gastric bypass, again, as per the IFSO position statement, we stand and support by the one anastomosis gastric bypass as a recognized bariatric procedure. However, we do encourage randomized controlled trials and collecting long-term data. One of the quotes from Albert Einstein: relativity applies to physics and not ethics. Thank you all. Looking forward to hearing everybody's feedback and comment. I'm sure this will spark a lot of discussion and controversy. Thank you. Thank you. Comment, I'm sure.
Thank you very much, Ashraf, for this great summary of the work and of the entire position statement. For questions, please type in your question in the question section and we'll address them, but we'll start the discussion among the panel. Dr. Hempens, why do you think this position statement was needed now?
I think it's the right time now because we really see a wild growth of procedures all over the world, and in high numbers procedures are being performed that haven't sustained the proof of time yet. And I'm talking about countries like mine, where I witness several new types of procedures that are being performed without any proof of efficacy or safety. So I think now is the right time that IFSO comes up with guidelines concerning those new procedures.
Dr. Cohen, so are we trying to address the symptom or the cause? What do we think the cause of the phenomena that we're living in right now is as a society?
What I think that we're living is something that surgeons are seeking for innovations without any scientific background. And what I mean by scientific background, we have to split this into two things. First, what matters is when an innovation comes, and to be clear, I think nobody who co-wrote this paper and the executive board who approved the paper, the IFSO executive board, is against innovation. We're all, the panel here, it's formed by people who innovated before many people were even thinking about metabolic surgery, for example. And we have to balance the efficacy against some measurable clinical outcomes. we need to prove in new procedures the amelioration of preventing important complications. So it's not reporting 100 cases with an A1C of 6.6 for diabetes, for example, after 1 year. We want to decrease the micro and macrovascular complications. So when we have those goals, all the mechanisms that Ashraf showed us, when the goals are optimized, the mechanism does not dictate the clinical utility. So the mechanism may tell a convincing story to patients, to an IRB to approve the protocols for payers, but we need to add improvements to existing therapies. And so far, with all procedures, we don't show this. And we're living the dawn of a new era of treating diabetes and obesity with the new drugs. And if we look at the data that the new drugs are showing us, it's based on several hundred patients with now long-term follow-up, and they seek for hard outcomes. They look for cardiovascular outcomes. They'll be out by July next year. It's a big semaglutide trial. Tirzepatide showed weight loss comparable to surgery in a huge randomized control trial. So we need robust evidence to put ourselves in a good place to provide patients their best outcomes. So what I think is not being against innovation, but doing the innovation to the right path.
So Ashraf, there were several questions addressing the presentation and trying to address the endoscopic section. So by endoscopy, did the society lump all endoscopic procedures together, or are they addressing specific endoscopic procedures?
So thank you, Ahmed. So first of all, we try to stay aligned with any procedure that had a previous IFSO position statement on its own by a separate task force. So the endoscopic procedures and the endoscopic sleeve gastroplasty, they are covered by an IFSO position statement, and we do stand by that statement. What we tell people is that we do recommend RCTs. We need longer term data, and it is our duty to tell the patients or to make sure that our patients have realistic expectations for weight loss and for resolution of comorbidities after endoscopic procedures, because they are a very useful tool and a very good bridge to people who are not candidates to surgery.
Dr. Cow, Dr. Cohen raised a great point of the difference between the studies done by the medical society and the surgical society, and the volume of patients probably is much easier to get in medical studies as opposed to surgeries. But why do you see this big difference between the medical society and surgeons? Surgeons nowadays we're facing this issue of innovation and not following the scientific method per se. Why is that? Why do you see it specifically among surgeons? Us were biased being surgeons, but why do we see this phenomena within our society?
I think we need to understand that medical treatment and surgical treatment are quite different. If you give someone a medical treatment, it is a tablet that they can take for a certain period of time. They can come off the treatment. But with a surgical treatment, quite often it is irreversible. So patients got to understand that when they have a surgical treatment, they are stuck with this treatment, and therefore to give someone a surgical treatment, we have to think about the safety of the treatment, which is the surgical treatment. We've got to protect the patient to make sure they understand the risks involved of a surgical procedure and also the surgeon's experience. So if you're giving a new surgical technique, introducing that to the patient also got to understand that this may not have long-term results. This may not be this, a surgeon's experience, that he hasn't done thousands of this particular procedure. And therefore, as Ashraf said, the patient is vulnerable. If you offer them a treatment, of course they will take it because you're offering them something, a hope that they can get out of a disease that they have lived for a very long time. So the difference is medical treatment can be short-term, surgical treatment is truly for life.
Thank you very much. And Dr. Shikura, now there are people who say the scientific method would actually slow innovation down. Do you believe that is true? And where do we stand as a society on this topic?
I think that it can slow it down, and that's fine. If it needs to be slowed down so that we're not rushing into something we'll regret later, then we should slow it down. You know, I was just thinking a moment ago, think of all the harm that can be built into the system if you don't have checks and balances. I come up with a new operation, I go to a meeting, I present it, everybody's impressed, they all want to do it. Now I'm making a lot of money for the company by giving talks and workshops how to do the operation. Well, let's say the operation long-term doesn't work. Not only have I harmed my patients, but all the patients of the people who attended my seminars and then wanted to do that operation, we've hurt all their patients. Now look at it on a more global view, we've hurt the organization and we've hurt the field. And we've done that repeatedly in the past. And that's what we have to break away. So if innovation is going to take a while, then let it take a while so that our results are believable and safe.
You know, Dr. Hempens, I've heard previous criticisms of us at IFSO, you know, addressing these innovative procedures in, you know, courses, workshops, and somehow this criticism is IFSO sending mixed messages. Now we have this IFSO position statement on innovative procedures. Meanwhile, all these procedures are being taught and you know, trying to promote these procedures. So where do we stand as a society?
Well, I think one of the most significant parts of IFSO's mission, and especially in the position statements, is that you may have noticed that they always or almost always mention that there should be a reevaluation within 2 or 3 years. And so it's not a standstill, it's not an opinion that's there to forever. And so IFSO opens itself to criticism and to reactions. Now, there's one word of caution though. In general, we assume that when we perform a study, provided there is an acceptance by the IRB, it's fine, and we can go ahead and do the procedure. 2 remarks. First, that makes the procedure very much dependent on the geography. There's IRBs from certain parts of the world, for instance, that will be very, very easy on giving their okay for a new procedure. So therefore, I think it's important that we should imply that whenever we do a study, we should register the protocol of the study before we perform that study, and perhaps submit that protocol to some type of a committee that could give its okay for that procedure to be done. I think we have to get that out of the local system of IRB. And like Ricardo said, we need to get really robust data. We need to have large studies from different centers and submit it to an overlapping, I would say, IRB okay.
I have, Ahmad, can I make a comment?
Please.
Jacques, when we designed a randomized control trial, we just published one a few days ago at the Lancet, where the medical treatment and surgery was the same regarding early stage kidney disease from diabetes. When we design this, a study has a beginning, the interventions, and an end. So sometimes I hear that I'm doing that operation X or Y through an IRB approved protocol, but it's a never ending protocol. So I think surgeons should be educated about what is levels of evidence, what is designing a protocol, and then I agree with you, it should be reproducible. And in the end, with robust data, we can, yes, change guidelines. The only way to change guidelines is through RCTs, and it's through some level 2 studies like the SOS study, for example, that help us to build a good basis of knowledge and reputation, scientific reputation. So I think we need that. And I agree with Lillian, the irreversibility of surgery should be taken into account. And second, Ahmad, your question, why internists are better than us doing studies? Because it's very expensive doing an RCT, surgical RCT. It costs sometimes millions of dollars. I'll tell you an example. Our RCT costed around $2 million. The Stampede trial, shower study, cost about $5 million. So it's too much money. And the devices company that usually support us, they don't have the money of the pharmas. So I think it's a different environment to produce knowledge in surgery than in the medical treatments. However, we need to stand and keep on pushing robust science to change guidelines. The endoscopic sleeve gastroplasty had its first RCT published 2 months ago at the Lancet, the Merit trial. It's the first step. So it's the first step, but one RCT doesn't mean that it's ready for prime time. We need to reproduce the results. We do have long-term data. I saw a question about the Bariatric. It fits the same. We need studies. We need RCTs. We need to prove that it's better than the standard operations like the gastric bypass or the sleeve gastrectomy and the medical treatment. So we need to be serious because the reputation, it's our only treasure that lasts forever.
So, Dr. Cohen, you mentioned great points, and I know you live in a geographic area that is very attractive to innovative procedures. And, you know, part of the Latin American chapter actually approved some of, in some societies, approved some of those innovative societies. So what do you say to a surgeon who mentions, hey, I've done thousands of these procedures and my results are great. Why should my procedure be labeled innovative?
Because usually it doesn't have any animal study that proves any mechanism on top of the known mechanism behind wrong gastric bypass and sleeve gastrectomy, the standard operations, first. Second, it carries the inherent biases of retrospective and prospective series. Level 3 and 4 evidence do not move the needle towards changing guidelines. And I'll give you an example. The ADA and the AFC put surgery in a square in the algorithm of treatment diabetes and obesity. And the operation that is suggested is the wrong gastric bypass because of its data, because of the 13 RCTs, because of the animal studies, because of the SOS study, because of the big data that was produced after the RCTs and before the RCTs. So it's a huge amount of data that promotes, that gives an upgrade to the operation as a standard one. So what I tell to the Brazilian Society did not approve any procedure, the experimental. This should be ruled by it's called the Federal Council of Medicine. It's the former NIH role that has in the US. We have the same NIH in Brazil that does this. And our local NIH did not approve any procedures, exactly because there's no animal data, there's no RCT besides gastric bypass and sleeve gastrectomy.
So, Ashraf, you started mentioning the road to recognizing a procedure. So if you want to tell the audience, what's the process of recognition of a procedure? So I'm a young and upcoming surgeon. I want to do the Nissen sleeve, for example, not specific, but for example, how do I start doing and aiding in the recognition of such a procedure?
Thank you, Ahmed. When I came up with the idea of putting this position statement together and put it forward to the scientific committee, I heard from other surgeons in other chapters that they have the same concerns. People are coming up with new procedures. What sparked this, or what gave me this idea, we were giving one of the revisional bariatric surgery courses to a young group of surgeons, and I asked them, what's the gold standard to treating diabetes? And none of the answers were any of the IFSO mainstream procedures, because they went to a course to someone who does one procedure, who told them it's a gold standard, let's say, for treating diabetes, and then they moved on. So what I advise these people if they want to, let's say, do a procedure, first of all, they should ask someone who is more experienced and ask for opinions before just start offering it to patients. We shouldn't be technicians. Look at the data. If a procedure, let's say, has one or two meta-analyses that show 10% complication rate and you still want to do it, then you better tell your patient that I'm doing a procedure that carries 9 to 10% complication rate, or I'm doing a procedure, let's say the Nissen Plication, because no one does it probably anymore. If I'm going to plicate you and do a Nissen, I'm not sure it's going to control your reflux, and at the same time, I don't think you're going to lose weight. And see if the patient is going to sign your consent and accept that. However, if you truly believe in a procedure, look through the literature, get the data, which is usually small single center series. Then put a proposal, send it to your IRB, and a proposal, it should have, as Dr. Cohen said, beginning point and then end point, right? And then the patients they have to be adequately informed that we are doing a procedure that has no long-term outcomes. And then the IRB, it's an ongoing process. You can't say, oh, I have IRB approval and keep on doing the same procedure for 5 years. The IRB has to evaluate the risk benefit throughout your process. If after the first year IRB finds out you have, let's say, 15% leak rate, they should stop you. So I think we should go back to the basics as scientists before surgeons, look at the data. If it's convincing enough, try to convince your own IRB, have a study design that's acceptable, and then publish your data. So I got a lot of emails, probably my colleagues did and Dr. Cohen did from his sort of area, about surgeons asking why their own procedure is not in this position statement. So we have surgeons saying, let's say, I'm doing the Bashir procedure or the Dr. Shikura procedure, and I've been doing it for 18 years. It's awesome. I've never published it, but I wanted to be recognized by IFSO. And these are emails that we got from the IFSO community. So Dr. Hempen said every position statement gets evaluated every 2 to 3 years. If someone feels strongly about the procedure, and then in 2 to 3 years, there's strong evidence that it works, and the evidence has to be reproducible, so we don't go through what we went with the band, then I'm sure the coming task force will definitely amend or change its current recommendation.
Thank you, Ashraf, for this detailed answer.
There's an interesting question by Jean. I think should be addressed to Scott.
Yes. Dr. Shikora, as an editor-in-chief of obesity surgery, Dr. Hempens mentioned, do you think medical journals should be more reluctant in publishing some papers with about procedures with limited volume or limited degree of evidence?
I guess you could view that different ways. I think number one is the quality of the paper. Number two, it could be a preliminary report with a small number of patients and a shorter follow-up, but it has to state that. Like we would call that a brief communication, where you're just saying, hey, by the way, everybody, I'm doing a study. I have IRB approval. So far, I've got 10 patients, interesting results, 6-month follow-up, more to come later. And I think that's fine, but I don't think you can write a definitive paper on short follow-up, small number of patients, and lousy or weak data. I think that paper shouldn't be accepted for publication, even if it's an interesting sounding procedure.
So
Maybe the journal could flag this is a pilot study with interesting data that can be followed by more robust data. Maybe we should flag this in the journal.
I think
We'll have to think about that. Because right now, the authors state it's a preliminary study.
I agree, Scott, but maybe an editorial.
I think an editorial comment can sometimes play that into perspective.
I agree.
Yeah.
We should
That
think
would
about
be
this.
another way to go, is to ask somebody to write a small editorial to go behind the paper.
sure.
So what do you mean? Yeah.
So I heard lack of a little bit of a lack of proper training on the scientific method. Maybe lack of training on bariatric surgery and bariatric procedures. Do we need IFSO to do more, Dr. Cao? Like designing a universal informed consent, for example. That's one. Additional training on the scientific method, additional training on bariatric surgery in general. What do you think?
Well, I think training is always important. Upskilling your skills is also very important. But I think at the end of the day, we must remember is the safety of the patient. You know, if you are going to implement a particular operation, you must think, is this operation safe for the patient? Am I skilled enough to give the patient the best operation that this procedure can offer? So training, of course, is important. Technique of the operation is also very important. And teaching people the skills of a certain operation, the operative technique is very important. So if someone is good at doing an operation, have done thousands of a particular operation, then this person must be able to teach that operation to someone else and make sure it is reproducible and also give the same results. And that's why, you know, multi-centered trials are important to show that a particular procedure is reproducible by different people.
If I could just add a couple comments, the idea of a IFSO informed consent is very attractive, but I think all the IRBs across the world want different things in their informed consent. And so we have one consent form that fits all the requirements of all the IRBs around the world. Secondly, I think we're really dealing with the surgeon who's done 1,000 or something. I think the discussion really the surgeon who's done 10 or something or 15, teaching it as a great procedure.
Yeah, that's a great point. And another point raised by Dr. Hempens is live surgery was not addressed in this position statement. Any reason why you think, Dr. Hempens, you wanted to raise that point?
Well, yeah, because I noticed that in many workshops and everything, we see that there's again a revival of live surgery, and there's been some evidence, and if so, back that up, that that may harm the patients. I remember there was a publication from the Brazilians. I think it was a year of 5 years ago, I think, and where there was a study that very clearly demonstrated that live surgery induced more morbidity than the regular procedures by the same surgeons. So therefore, is it worthwhile? I mean, I have no opinion on that, but is it worthwhile to readdress that specific issue? Because I see that's something that's really happening all over the world now again.
I think you're right, Jacques. After that paper, the Brazilian Society do not endorse any courses with live operations. And in our Congress that we used to have back in the mid 2000s, we don't do that anymore because it harms the patient, it adds more complications, and I think IFSO should have a position regarding that. And the second thing is, in some courses, people do innovative operations without any scientific background to teach people to do this. And if the surgeon has the IRB approval and is an operation under the protocol, I believe that that should be allowed to be shown. However, if there's a never-ending protocol that I wrote a protocol 10 years ago, still doing cases, IFSO should have a position because that harms patients and harms bariatric surgery.
You know, the 900-pound gorilla in the room, the one thing that nobody's brought up yet is industry. And industry drives a lot of these courses to educate people to do these operations so they could sell more devices. So maybe it's IFSO going to industry and saying, we thank you for your support. We're going to have a lab, but we're not going to have live surgery.
Right.
So we do have a position statement on live surgery, but I think it's due for an update. That was around the time Dr. Higa was president, so that's probably around 2017. So probably we need to have an update and look at the new data. And we do have an endorsement process of courses, and we look at experimental versus established procedures. So maybe the endorsement process can emphasize the innovative procedures as well. I think we're almost about time to end this very interesting and exciting webinar. So I'll leave it on final notes from everybody. I'll start with you, Ashraf.
Thank you, Ahmed. A pleasure seeing you all, and it was a pleasure to be able to present our thought of process behind this position statement, which I know a lot of dear friends and colleagues took it differently. We are not trying to ban procedures or to limit the progression of any surgeon, but it has to be done the right way, and our basic aim to provide safer procedures to the patients.
Dr. Cal?
I think we go back to first principles. When we first became doctors, we took the Hippocratic Oath not to harm our patients. So the quality of care and safety and patient outcomes must be paramount in whatever we do to those patients. They are our patients. We must look after them.
Dr. Cohen?
Yeah, I second Lillian's and Ashraf. We need to be serious. We're not against innovations. We need innovations. Our patients need other alternatives, either medical or surgical, but do it the right way. Do it with ethics, responsibility, and follow the hypothesis. Let's do it right.
And Dr. Hempens?
Well, I really must commend Scott Chikora for his words. I think one of the biggest problems is nowadays still is industry. And we must make sure that there's no conflict of interest whatsoever in data that we present in conventions and procedures, in publications, etc. We really have to make sure we are objective and not led by the industry or by the financial interests of industry.
And Dr. Sikora, I'll leave the final note to you. And one question also raised by Dr. Hempens, there are some procedures that have never been proven, and like laparoscopic cholecystectomy. Should we aim at addressing those? Should we make the distinction between the procedure itself and the approach? And your final note as well. That's a tough question.
Is that for Dr. Hempens?
Yes.
Okay, well,
But my question is that when we look back in history, we see that procedures came up without evidence at all. And my question is, how can we, in that forest of procedures, find out, looking back, not looking forward, but looking back, how we could address that? And I mean, lab chole, I remember the early days that people said that will never work, and there's criminals, the people who did. I was called a butcher because I started doing laparoscopic Roux-en-Y gastric bypass. So it's just a general thought. How can we deal with that? Roux-en-Y gastric bypass.
Well, first of all, I want to thank
procedure, but just the fact that doing it laparoscopically, does that change anything? That's my question, actually.
I want to thank Ashraf for a great presentation, Ahmed for this wonderful session. That's a really tough question. I think some of the operations that are no longer being done, they basically have self-determined their history, and I don't think we need to take them out of mothballs to look at them. I think it's the ones that are still active that maybe we need to assess, such as some of the procedures that we saw in the presentation, to look at them now critically for bias in patient selection, bias in outcome results, safety, efficacy. You know, we always talk about safety, but we need to also talk about efficacy. That if a procedure is safe but not efficacious, it's really of no benefit either. I just, my final closing note would be that all of us need to behave in an ethical manner in our practices and not to be lured by fame, fun, the opportunity to become the guru for that procedure. And always remember, we're taking care of human beings. That could be our mother, our father, our sister, our brother. So we should treat everybody with that type of honesty and respect.
Thank you all for the great points, great webinar, great work, and much needed. And hopefully we can build up on it and continue to progress in ethics and innovation as well. A reminder, if you want to actually tell others who missed it to rewatch on YouTube or the Virtual Academy. Thank you all, and hope to see you soon.
Thank you.
Bye.